Today's audio lecture is on Chapter 29, Assessment of the Respiratory System, Chapter 30, Care of Patients Requiring Oxygen Therapy or Tracheostomy, and Chapter 31, Care of Patients with Non-Infectious Upper Respiratory Problems. The objectives of today's lecture is to describe the basic assessment and nursing management of patients with upper, lower, and accessory muscles of the respiratory tract, review effective communication when teaching patients and families with respiratory issues, distinguish between normal and abnormal breath sounds. We're going to identify respiratory changes associated with aging, discuss physical, psychological, and diagnostic assessment of patients with respiratory problems. We're also going to talk about the different anatomy associated with the respiratory system, upper respiratory tract, the pharynx or throat, larynx, which is the voice box, and the lower respiratory tract, which includes the trachea, the mainstream bronchi, etc. I'm not going to go a lot into detail. Right here, you can see a graph of the places and where they're located. It'll be your responsibility to know what the functions of these areas are that we're going to focus in on. I would like you to know about the upper respiratory tract and how it consists of the nose, sinus, and pharynx and larynx voice box. Um, you see there, we have like the nose and sinuses. Um, this organ is rigid and contains two passages separated in the middle by the septum. The upper one third of the nose is composed of bone. The lower two thirds is composed of cartilage. The anterior nares um, are lined with skin and hair, which help keep foreign particles or organisms from entering the lungs. You also have what they call the turbinates, which increase the total surface area for filtering, heating, and humidifying inspired air before it passes into the nasopharynx. The paranasal sinuses are air-filled cavities within the bones that surround the nasal passages, lined with ciliated membrane. The purpose of the sinuses are to provide resonance during speech and to decrease the weight of the skull. You have the pharynx or throat, and it's a passageway for both the respiratory and digestive tracts. The throat is divided into the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is located behind the nose, above the soft palate. The eustachian tube is a tube that connects the nasopharynx with the middle ear and opens during swallowing to equalize pressure within the middle ear. You also, I will focus in on the laryngopharynx, and it's located behind the larynx, extended from the base of the tongue to this esophagus. It is the critical dividing point where solid foods and fluids are separated from air. That may be an important point to know about the laryngopharynx. Uh, Also, when you start talking about the lower respiratory tract, it consists of the trachea, the two mainstream bronchi. Um, the another name for the lower respiratory tract would be called the tracheobronchial tree. Is an inverted tree-like structure consisting of muscle, cartilage, and elastic tissues. The trachea also has another name which we call the windpipe, and it's located in front of the esophagus. It begins at the lower edge of the cricoid cartilage of the larynx and extends to the level of the fourth or fifth thoracic vertebrae. And other than that, we can talk about the bronchioles and the alveolar ducts and go down. But I just basically wanted you to know what the anatomy of the respiratory system consists of. Okay. So when we do a anatomy, um, and physiologic review. A lot of times I talk about the lungs or sponge-like elastic cone-shaped organs located in the pleural cavity in the chest. It's composed of millions of alveoli and their related ducts, bronchioles, and bronchi. Um, for testing purposes, usually there is a question about right lung, which is larger than the left and is divided into three lobes, upper, middle, and lower, and the left lung, which is somewhat narrower and smaller than the right lung to make room for the heart, is divided into only two lobes. A lot of times there is test questions which distinguish the difference between the right lung and the left lung. The pleura is a continuous smooth membrane composed of two surfaces that totally enclose the lungs. The accessory muscles of respiration, um, which are considered the scalene muscles, which lift the first two ribs, and the sternocleidomastoid muscles, which raise the sternum. The trapezius and the pectoralis muscles fix the shoulders. Pay important attention to respiratory changes which are associated with aging. Many changes in older patients result from hereditary and a lifetime of exposure to environmental stimuli. You may have somebody that smokes cigarettes. They might be exposed to bacteria, air pollutants, or industrial fumes and irritants. Respiratory distress is a major cause of illness and chronic disability in older patients. Okay, here is a small video on the functions of the respiratory system.
Hey, do you want to learn more about the respiratory system? Good. Then I will tell you all about it. Well, first off, some functions of the respiratory system include supplying oxygen to the blood so it delivers oxygen to all parts of the body, ventilating the lungs, extracting oxygen from the air and transferring it to the bloodstream, excreting carbon dioxide and water vapors, and maintaining the acid base of the blood.
Wow, that's a lot of functions.
Yes, there is. Now, I will tell you about the functions of parts of the respiratory system.
No, you don't have to.
Don't worry. I want to. Anyways, I will tell you more about the functions of parts of the respiratory system, such as the lungs, nose, trachea, bronchi, larynx, diaphragm, and the alveoli. So, the lungs are a pair of conical organs, and they are the main organs of the respiratory system. In the lungs, oxygen is taken into the body, and carbon dioxide is breathed out.
What happens next? How are oxygen and carbon dioxide exchanged and transported throughout the body?
The oxygen and carbon dioxide is exchanged and transported throughout the body by red blood cells, which are responsible for picking up the oxygen in the lungs and carrying the oxygen to all the body cells that need it. And then the red blood cells drop off the oxygen to the body cells and pick up the carbon dioxide, which is a waste gas product produced by our cells. The red blood cells transport the carbon dioxide back to the lungs, and we breathe it out when we exhale.
What's the next organ?
The next organ is the nose, where air is inhaled and exhaled. The cavity of the nose is divided into two parts by the nasal septum. The superior and lateral walls of the nasal cavity are formed of the nasal, maxillary, ethmoid, frontal, and sphenoid bones. Next is the trachea. The trachea is sometimes known as the windpipe, which filters the air we breathe and branches into the bronchi. The bronchi are two air tubes that branch off of the trachea and carry air directly into the lungs. The larynx, also commonly called the voice box, is an organ in the neck that is involved in breathing and protects the trachea against food aspiration and connects the trachea with the laryngopharynx.
Oh my! You sure know a lot of facts about the respiratory system. Are you almost done telling me all of this?
Nope. Not even close. Now, the three important cartilages of the larynx are the epiglottis, thyroid, and cricoid. The epiglottis is the cartilage that prevents food from entering the respiratory tract, otherwise you would choke, which I will now demonstrate. I'm fine. But anyways, that is what happens if food goes down the wrong pipe. Now I will resume my lecture. Next is the diaphragm, which is a dome-shaped muscle at the bottom of the lungs. When you breathe in, the diaphragm contracts, and when it contracts, it flattens out and pulls downward. This movement enlarges the space that the lungs are in, and this larger space pulls air into the lungs. When you breathe out, the diaphragm expands, reducing the amount of space for the lungs, forcing air out. The diaphragm is the main muscle used in breathing, and the alveoli are sac-like bodies present inside the lungs. The alveoli functions as an interface for exchange of oxygen and carbon dioxide between the lungs and capillaries that connect with the rest of the body.
Then what are the mechanisms involved in breathing?
The mechanisms involved in breathing are the nose, diaphragm, trachea, lungs, alveoli, and intercostal muscles. Oxygen would enter the body through the nose, and then it passes through the trachea. The diaphragm would push down on internal organs, freeing up space for the lungs to expand, and then the intercostal muscles between the ribs elevate the rib cage and push it out. The expansion creates negative pressure in the lungs, and the higher pressure of the atmosphere draws air into the lungs. The oxygen diffuses into the blood, running through the capillaries around the alveoli sacs that line the lungs. Carbon dioxide also moves to a lower concentration to the interior of the lungs from the blood. And do you know what initiates inhalation?
No.
Well, inhalation is initiated by the diaphragm and is supported by the external intercostal muscles. Normal resting respirations are 10 to 18 breaths per minute, with a time period of 2 minutes. And during rigorous inhalation, accessory muscles of respiration are needed for support. Such accessory muscles include pectoral muscles and latissimus dorsi.
That is quite interesting.
Yes. And under normal conditions, the diaphragm is the primary driver of inhalation. When the diaphragm contracts, the rib cage expands, and the contents of the abdomen are moved downward. This results in a larger thoracic volume and negative pressure inside the thorax. As the pressure in the chest falls, air moves into the conducting zone. There, the air is filtered, warmed, and humidified as it flows into the lungs. And during forced inhalation, the external intercostal muscles and accessory muscles aid in further expanding the thoracic cavity.
That is very cool. Do you know anything else about the respiratory system, or are you done?
I know a lot more facts and information that I think you should know about.
Yay.
I shall proceed to tell you about exhalation. Active and forced exhalation is achieved by the abdominal and the intercostal muscles. And during this process, air is forced, or exhaled out. And lungs have a natural elasticity, so when they recoil from being stretched out from inhalation, air will flow back out until the pressure in the chest and the atmosphere reach equilibrium.
What's next? The major function of the respiratory system.
Sure. I will tell you all about that. The major function of the respiratory is gas exchange between the circulatory system and the external environment. In humans and mammals, this change facilitates oxygenation of the blood with the concomitant removal of carbon dioxide and other gaseous metabolic wastes from the circulation.
That sounds disgusting.
That may be so, but removing such gaseous wastes helps maintain the acid-base balance of your body as part of homeostasis. If proper ventilation is not maintained, then two things can occur: respiratory acidosis, a life-threatening condition, or respiratory alkalosis.
So if carbon dioxide and other wastes weren't removed from our circulation, then we can end up with those conditions that can kill us?
Yep. Interesting, huh?
So, are you done with the lesson yet?
Not even close. Oh ho ho, I am not even halfway done yet.
Are you serious?
I am very serious. You cannot joke about the respiratory system and its functions.
But aren't you running out of breath from telling me all of these facts and information?
Not at all, because my lungs and diaphragm are doing their job. by supplying me with oxygen to keep talking.
I see.
Now then, I will tell you about how lungs have defense mechanisms. Lungs have airway epithelial cells that can secrete a variety of molecules that aid in lung defense. Secretory immunoglobulins, collectants, defensins, and other peptides and proteases and reactive nitrogen species are all generated by airway epithelial cells. These secretions can act directly as antimicrobials to help keep the airway free of infections. Airway epithelial cells also secrete a variety of chemokines and cytokines that recruit the traditional immune cells and others to the side of infections. Lungs also have a number of metabolic processes, such as containing a fibrinolytic system that lyses clots in the pulmonary vessels and releasing a variety of substances that enter the systemic arterial blood, and they remove other substances from the systemic venous blood that reach them by the pulmonary artery. Prostaglandins are removed from the circulation, and they are also synthesized in the lungs and released into the blood when lung tissue is stretched. The lungs also activate one hormone, decapeptide angiotensin. Do you know why people yawn, sneeze, or hiccup?
No, I do not.
People yawn because the lungs do not take enough oxygen from the air, which causes a shortage of oxygen in our bodies. The brain senses this shortage of oxygen and sends a message that causes you to take a deep, long breath. And you sneeze because it is the body's way of removing an irritant from the sensitive mucous membranes of the nose, and many things can irritate the mucous membranes such as dust, pollen, pepper, or even a cold blast of air, and people hiccup because they are sudden movements of the diaphragm. It is an involuntary movement, which means you have no control over them. Some causes of hiccups would be the irritation of the diaphragm, or eating too fast, or maybe some substance in the blood could have brought on the hiccups. Interesting facts, right?
Sure.
Oh my. Look at the time. You're probably busy with things, so sorry for taking up 10 minutes of your time talking about the respiratory system. But I can tell you had a great time listening. Well, I'll be going now. I hope you learned a lot about the respiratory system, because this lesson is finally over. I hope you enjoyed this 10-minute presentation on the respiratory system.
Okay, I hope you enjoyed the video on the respiratory system. We're going to talk about what the role of the respiratory system is. Um, the main role of the respiratory systems is there's a specific human need, um, which is basically for oxygenation in the body and tissue perfusion. And that is important for the lungs and the heart and the red blood cells oxygen delivery. When you are taking a patient history, for example, you need to collect history of the patient's data on family, personal smoking, drug use, allergies, travel, place of residence, dietary history, occupational history, and socioeconomic level. Um, that's really, really important because you may, based on a person's occupation, if they're working in a place like, for instance, a mine or something like that, or if they have allergies determine whether or not the person is living in a home with pets, or they have a familial history of like asthma or something. That makes a big important impact. Usually people who have a lower socioeconomic level these days tend to be more of heavier smokers. So like things like that are things that you need to take into consideration. I will want you guys to do what they call a pack years of smoking. Basically, you document in number of packs smoked per day, and you multiply the number of years the patient has smoked, and then that's how you determine pack years of smoking. You document a number of packs smoked per day. So if let's say the person smokes 2 packs of cigarettes per day, and they've been smoking for 10 years, you'll know that that person is a pack years a smoker of 20. Generally, too, people often tell you less, that they smoke less than what they actually really do. So that includes use of cigarettes, cigars, pipes, tobacco, marijuana, and any other controlled substances as well. You want to ask about the patient's history, ask about home and living conditions, as I said before, assess current health problems such as cough, sputum production, chest pain, and or dyspnea. If they are using drugs, both prescription and illicit, and of course, like I told you before, allergies to drugs, food, dust, trees, molds, pollen, and animal dander. Okay. Also, you want to know whether or not they have traveled all out of an area that's an unknown geographical area of residence for them. Nutritional status, if a person's allergic to reaction to food or preservatives, and whether or not the family has a genetic history and genetics. The cough. The cough is basically a main sign of lung disease. You need to, when you're assessing a cough, you need to determine whether the cough is productive and or non-productive, congested, dry, tickling, or hacking. Um, when you look at a person's sputum production, you want to know whether or not is in um, whether or not if the sputum may be clear or white, tan, or gray, or something like that. If an infection is usually present, people tend to have a yellow or green sputum. Describe the consistency of the sputum, which it consists of is the it thin, thick, watery, or frothy. You want to see whether or not there's an excess of pink, frothy sputum is common. If a person has, like for instance, a pulmonary edema, you want to assess pneumococcal pneumonia, often produces like a rust colored sputum, and foul smelling sputum often occurs with the lung abscess. Hemoptysis, which is basically blood in the sputum, is most often seen in patients who have chronic bronchitis, and that's or lung cancer. And a lot of times with the bronchitis, that's just related to them having like the inflammation and them, having the cough so more much and the irritation. Patients with TB or pulmonary infarction or bronchial adenomas, which is a tumor or lung abscess, may have grossly bloody sputum. You want to quantify the sputum by describing its volume in terms such as teaspoon, tablespoon, in cups or fractions of cups. Normally, the bronchial tree can produce up to 3 ounces, which is equivalent to 90 milliliters of sputum per day. A lot of times, chest pain can occur with other health problems as well as with lung problems. Ask the patient whether the pain is continuous or made worse by coughing, deep breathing, or swallowing. Cardiac pain is usually intense and crushing. It may also radiate to the arm, shoulder, or neck. Pulmonary pain varies depending on the cause. Pain that feels like something is rubbing inside is more common with pulmonary pain. Okay, when a person has dyspnea, which is difficulty in breathing or breathlessness, it can be what we call more of like a subjective perception and varies among patients. Determine the type of onset. Is the dyspnea slow or abrupt? The duration, number of hours, times of day, what helps the person relieve that shortness of breath, changes of position, drug use, activity cessation, and whether or not wheezing, crackles, or stridor occurs with the breathlessness. Also, you want to know if a person has what they call PND, which is paroxysmal nocturnal dyspnea, and it's which is intermittent dyspnea during sleep. The patient has a sudden onset of breathing difficulty that is severe enough to awaken him or her from their sleep. Another terminology is orthopnea, which is a shortness of breath that occurs when lying down but is relieved by sitting up. These two conditions, the PND and the orthopnea, often occurs when a person has chronic lung disease and or left-sided heart failure. Here is just basically a physical assessment of the noses and sinuses. That you have the frontal and the ethmoid and the maxillary and the sphenoid. If you want to be using like the correct terminology, I employ you to look at where the arrows are pointing and use that terminology. Um, so we're going to talk about individuals and assessing the physical assessment of the nose and the sinuses. When you go in and you look at a patient, you want to inspect the nose for whether or not they have any type of deformities or tumors. Inspect the nostrils for symmetry of size and shape. You need to just kind of be aware of whether or not something has changed. It's all right to ask the patient um, if has something changed as far as their nasal passages. Inspect the color. You want to inspect for like irritation, redness when you look up there, swelling, any drainage. I mean, they may have really bad sinuses or bleeding. Check the nasal septum for bleeding, perforation, or deviation. All of those type of things can assess or affect how a patient breathes. You want to also check for perforation. Sometimes bleeding and perforation could be indicative of someone using even some type of drug abuse. Um, you want to block one nares at a time to see if when they breathe through it, if there's a movement of air. You want to check if they have what they call nasal flaring, and that's when the nasal passages open like really wide. Uh, and the reason why a lot of times they do that is when they're having, you'll see a lot of people with COPD do that because they're having really hard time breathing as well as severe asthmatics. You want to see oh, like I mentioned earlier, where right here it says perforated septum is often found in cocaine users, and nasal polyps are pale, shiny, um, gelatinous lumps or bags attached to the turbinates. Okay, so right here again, um, you can take notice or look at that, and that was just an inspection of the throat area, like the pharynx, trachea, and or larynx. I would employ you to know the difference between the pharynx, the trachea, and the larynx. Um, Inspect external structure of the mouth. You want to see whether or not there's any type of nodules or lumps or deviations. Use your tongue depressor to examine the posterior pharynx for the same. And you want to inspect the neck for palpate for lymph nodes, size, shape, mobility, consistency, and tenderness. Tender nodes are usually movable and suggest some type of inflammation. You want to check that malignant nodes are often hard and fixed to surrounding tissue. So they won't move, but you know that it's something abnormal. You may want to just keep that thought in your mind, and that would be like a text, a test question about the consistency of nodes and whether or not something might not be malignant or whether something is malignant. Palpate the trachea area space on each side and it should be equal. Attention pneumothorax, large pleural effusions, and mediastinal mass neck tumors if you push trachea away from the affected area. A pneumothorax fibrosis or atelectasis pull trachea toward affected area. So you want to look um, that way to assess. Okay. So once again, we do have the anatomy, and I just employ you to be pretty proficient in knowing just if you just know what your areas on your respiratory system are, what they consist of, and you look at them and you know what do that area do. That would be a good start. So occasionally I may ask if you have a respiratory person, or if you're telling me that you're assessing a respiratory person, um, I may ask that, and you should be able to tell me in a medical terminology way what areas this is as far as physical assessment and use your proper medical terminology when you're discussing it. The physical assessment of the lungs and thorax, you want to talk about age, gender, and race, and it can affect physical and diagnostic findings. So you want to use the assessment inspection method. You assess front and back of the thorax. You observe the chest and compare one side with the other. You inspect for discoloration, scars, lesions, masses, spinal deformities, and you observe the rate, rhythm, and depth of inspirations. You observe type of breathing, use of accessory muscles. Okay, so what we're saying basically, you guys, is when you inspect a person's back and you inspect their front, you observe the chest. You're going to compare each side. You want to see whether or not it's not equal. You want to see if there's any scars or lesions, or maybe in the past the person had some type of surgery. You also want to look at how they're breathing. Um, we'll be discussing like people who have COPD and people having like the burrow chest and the different the use of like their diaphragm to breathe and stuff. That kind of thing could let you know whether or not a person is having difficulty breathing. Okay, then, so first we did talk about the inspection method. Now we're talking about palpation. Palpation is performed to assess respiratory movement, symmetry, and observable abnormalities. Palpate the abnormalities found on inspection. What you'll probably get real good at is when you touch a person with your hand and you palpate areas like around their rib cages and their diaphragm and down the back, you'll get good at noticing whether or not you might feel a lump or a mass or a lesion or something. But as far as like palpating for like the tactile fremitus or something like that, um, that or crepitus, a lot of times, especially novice people, or if even older nurses that haven't worked around respiratory people a lot, have a hard problem, really, really noticing that. If you palpate for tactile fremitus and how the vibration of the chest wall is when the patient speaks. Just know that if it's decreased, it may be a pneumothorax or pleural effusion, and if it's increased, it may be pneumonia and or like an abscess. As you can see, down here I did post the chart, and I want you to be able to know and be able to determine like the difference between these types of pitches when you're assessing the lungs. Like for instance, here we have the resonance, and it's a low, hollow. finding, and it's characteristic of normal lung tissue. So when a person is breathing in and they're saying that it's low and hollow and characteristic of normal lung tissue. Then you have what they call hyperresonance, which is higher than resonance, which is the normal sound, and it sounds like a booming. All of these are indicative of different types of respiratory um, problems that, like for instance, this may be an asthmatic or a person with a pneumothorax. Then you have a flatness, which is the pitch is high and the quality is dull, and that's example of a massive pleural effusion. So going on down, if you was to hear all of these different sounds, I would like for you to just be aware of the findings and the characteristics as far as normal lung tissue or some type of adventitious finding. Also, most of you guys, we've talked about, pretty much it should be all of you, about assessing for the respiratory status and how you assess the lungs and the thorax. So you got the left upper lobe and right upper lobe, and just how you go, and it's showing you, like, you see how it has the one and the two, then you come down, then go over to the four, and we've discussed this all before, but this right here is showing you the posterior as well as the left side, right side, and the anterior way that you assess for lung sound. So, as far as order is concerned, I would employ you to know, like, the order. And a lot of times, the reason why you assess it the way you would assess it is because you definitely want to compare the sounds. Okay. Physical assessment of the lungs and thorax. This consists of auscultation, listening for normal breath sounds, adventitious sounds, and/or voice sounds. You begin at lung and moving side to side toward the bases. Like I said, going side to side, you listen to full respiratory cycle, noting the quality and intensity of the breath sounds. Described as normal, increased, diminished, or absent. So when you um, or charting, and for charting purposes, because I tend to get on the people in my clinical about their terminology and expressing things the correct way, always going to whether or not it's normal, increased, diminished, or absent. I mean, when you're charting what side, where, on the base, where, so that's the way you need to be charting. The normal breath sounds are produced as air vibrates while moving through the passage from the larynx to the alveoli. Adventitious breath sounds indicate some type of pathological changes in the lungs. So that would tell you that adventitious means that it's nothing that is a positive thing. It's something that's abnormal. Voice sounds are muffled, unclear through normally air-filled lung. Okay, so we just discussed about adventitious breath sounds, and I described them as something that's really not nothing normal that you would want to hear. So, adventitious, if I put on a test, for example, that a person has adventitious breath sounds, and I give you examples, and I say that resonance is a adventitious breath sound, is resonance normal or abnormal? So, based on that, you would know that resonance isn't considered adventitious breath sound. So, as far as the adventitious breath sounds, you have like fine crackles, which coarse crackles, wheezing, bronchi, and pleural friction rub. You're able and can do good to describe them on yourself, but this is the list of what we consider adventitious breath sound. And I want you to know, when you listen to adventitious breath sounds, what type of disease process would be maybe associated with someone having an adventitious breath sound. Right here, I'm ready to play some examples of some adventitious lung sounds, six in total.
Two basic types of adventitious or added breath sounds are the discontinuous sounds, crackles, and the continuous sounds, wheezes and rhunci. Crackles are intermittent, non-musical, and brief, like dots in time. Fine crackles are soft, high-pitched, and very brief. Coarse crackles are louder, lower-pitched, and longer. Compared to crackles, wheezes and rhunci last much longer and sound more musical. Wheezes are relatively high-pitched and have a hissing or shrill quality. Rhunci have a lower-pitched, snoring quality.
Okay, all right now. We finished with the examples of the adventitious breath sounds. Feel free to listen to them as many times as you want. And also, you can get a lot of good examples. I'm going to post this on, I'm going to give you the link so that when you click into Evolve and then you go here, of course, and you can listen to them as many times as you want. Also, you can also pull up on YouTube and hear, um, find other examples of the above. Okay. So the whole thing when we talk about respiratory system is that you want people to have adequate oxygen levels. There are so many things that can be controlled by how well a person transports oxygen, in their blood. I mean, it's things even like disease processes or endocrine problems, even diabetes, and stuff like that. Um, what are some indicators? Like, for instance, when you're a nurse and you're looking around at people, you'll start to notice things that happen to people, and you'll know in your heart why this person may or may not have um, this may be an indicator of them having a respiratory inadequate respiratory status. I'm sorry. So this would be like, for instance, clubbing. What is clubbing? Clubbing is like when a person's fingertips, for instance, look like, I don't know, like a frog on the ends of it. And that happens as a result of them just not having adequate tissue perfusion, which needs to be oxygenated and everything. I've noticed that on people, a lot of times, people who are diabetic for a length of time or people who are constant smokers, I've noticed people having problems with clubbing. Also, weight loss. They tend to have weight loss because people who have large respiratory problems tend not to eat like you would be accustomed to seeing that. Then unevenly developed muscles, skin and mucous membrane changes. They'll have general appearance, muscle development, general body build. They tend to be just really kind of emaciated, or they may be heavy. So it's usually like from one to the other. Endurance, they don't decreases when breathing is inadequate for effective gas change. So endurance meaning that a person is not going to be able to sustain a lot of activity. it decreases when they can't breathe, which makes sense. And of course, cyanosis, that's a very big, when a person looks blue, indicator of a person not having adequate respiratory um, exchange. Okay, some respiratory problems may be worsened by stress. Like for instance, you've heard of people they get stressed out or worried, and then all of a sudden they go into a asthmatic attack. Chronic respiratory disease may cause changes in family roles, social isolation, and financial problems due to unemployment or disability. A lot of people, when they have respiratory problems, they don't go out as much. They don't do as much because it just takes so much energy. So they do tend to isolate themselves. Or if they're advanced stages of some type of COPD, they may not walk around. They might have an oxygen tank, a little shoulder kind that they might have to walk around with. And a lot of people don't like to be involved with that. So you'll find that people, when they have those type of problems, they tend to be, socially isolated, as well as like even students. Maybe a student may not try out for athletic activities and stuff as they used to because of the fact of their respiratory decompensation. So you need to discuss, coping mechanisms and other access to support systems based on what their disease process is. Okay, these are the common laboratory tests that are administered for people based on what their respiratory status is. I would like you to know. Remember, I was telling you about you can do the red blood cells and that type of thing. Hemoglobin is really important, or arterial blood gases. The red blood cells, hemoglobin, arterial blood gases are the main things that will tell you what their CO2 level is, which is carbon dioxide and O2 levels. Say to yourself what you think um, their status will be. Say to yourself what do you think their oxygen level will be based on um, what their labs are. I want you guys to know what the normal ranges of the RBCs, hemoglobin, and ABGs are. They have sputum tests, a lot of different sputum tests. Checks people for some type of respiratory problem. Like they got the little acid tests and various things that they do on people so that you see, what's going on. A lot of times, if a person is diagnosed for lung cancer, they might do a cytologic examination of an early morning sputum specimen, and it might identify some tumor cells. However, cancer cells may not be present in the sputum, but that is one way. When a pleural effusion is present, fluid can be obtained from what they call a thoracentesis as well. So, and then we already know what the normal range of a pulse ox is, when you put it on the finger. So just know those tests. We talked about this. I kind of went ahead of myself. Chest X-rays. You can see pneumonia or whatever. And a lot of times you'll be reading a chart and a person will come in and they'll say that a person has an infiltrate when they looked at their chest x-ray. That's basically their way of saying pneumonia, atelectasis, and pneumothorax, and those are all collapsed lungs. Um, CTs can identify pulmonary embolisms, um, and I just want you guys to be aware of these various tests here and what you need to do. A lot of times people have what they call pulmonary function testing, and the main reason people have pulmonary function tests is to evaluate lung volumes and capacities. Flow rates, diffusing capacity, gas exchange, airway resistance, and distribution of ventilation. The main thing I want you to know about pulmonary function test is the patient preparation, which will consist of 6 to 8 hours of no smoking prior to the test. Procedure for performing tests at the bedside and most common reason for performing, and it identifies the cause that they have a shortness of breath or dyspnea. And after that, there's basically no real follow up care other than you're gonna observe the patient for increased dyspnea or bronchospasms. So I would like for you to know about that. Other testing and follow up care would be exercise testing. Uh, uh, um, they want to see whether or not the person can perform their activities of daily living, and differentiates reasons for exercise limitation. And also, you're going to do a skin test. Everyone knows what that would be. Most of the skin testing is just for TB, the PPD, and that's usually for. Sometimes people tend to have problems with the PPD allergy test, and as a result, the person will do the test, and then the person who has an extreme reaction to the PPD to test for tuberculin, they usually have to get a chest X-ray ever so often. They have what they call endoscopic examinations, and they're done to remove foreign bodies, collect specimen, or identify disease processes. They can do bronchoscopy, tube inserted in airway to second bronchi. And basically, when a person does um, bronchoscopies or laryngeoscopy or a test like that, they usually go down there and they get a biopsy. There's usually been some type of pathophysiology going on where the person is coughing up blood, or they visualize something on an x-ray or something. And a lot of times you'll see people go in there and um they'll grab a specimen. So right here, they say that the benzocaine spray is a topical anesthetic used to numb oral pharynx. Um, and you just got to be make sure that you don't leave it on there too bad so it won't damage the skin. Um, Thoracentesis, everyone knows what that is when you go into the pleural fluid area around the lung area, and this is really considered like almost like a procedure, like an operation or outpatient procedure. So when you do a thoracentesis, they have to get a consent signed by the physician, um, and the patient preparation is for stinging sensation and feeling of pressure. And the person needs to sit up, and the patient needs to be motionless to avoid puncture of pleura or lung. And the follow up is the main things is to assess for shock, which will consist of tachypnea, cyanosis, nausea, diaphoresis, or dyspnea. And you want to assess for bleeding, and that's at the puncture site. And then you just want to make sure that if you have any problems, that you assess the patient for pneumothorax and or mediastinal shift, and monitor vital signs as well for breath sounds. So this is basically just showing right there. And you see how they have the patient leaned over, and they got to make sure that they do not move when they're doing that test. Lung biopsy, really, they trying to figure out whether or not it's a person has cancer. And it's the same type of procedure almost as a thoracentesis. Follow up care. Assess vital signs, breath sounds at least every 4 hours for 24 hours. Assess for whether or not they have dyspnea, they're pale, they're sweating, and they got a tachypnea. report reduced or absent breath sounds immediately, and monitor for hemoptysis, which is them bleeding. Which nursing, we have some review questions for this chapter, and you can read this on your own, and we'll probably be trying to discuss these questions and ask everybody if they get a chance to read it what they thought the correct answer was. So this is for review questions 2 as well. Okay, and 3. Okay, so we're going to move on to chapter 30, which is care for patients requiring oxygen therapy or tracheostomy. Objectives would be discuss safe and effective care for patients requiring oxygen therapy, review different types of oxygen delivery systems and equipment, discuss focused respiratory assessment and reassessment to determine adequacy of oxygenation and tissue perfusion, identify laboratory data and clinical manifestations to determine presence of hypoxemia or hypocarbia, um, discuss safe and effective care for patients requiring tracheostomy care, review safe use of tracheostomy equipment, and discuss prevention of aspiration in patients um, with tracheostomies. I want everybody to know what hypercarbia is. Hypoxemia means, of course, that you have low oxygen. As a result, a lot of times when people have respiratory problems, they tend to have a high carbon dioxide level. Okay, oxygen content of atmospheric air is 21%. So hypoxemia is low levels of oxygen in the blood. Hypoxia is decreased tissue oxygen. So there's a totally different terminology there that I want you guys to be aware of. The goal of oxygen therapy to use the lowest fraction of inspired oxygen for an acceptable blood oxygen level without causing harmful side effects. Conditions that decrease oxygen capacity would be heart failure. I can see that, sepsis, poor hemoglobin quality, fever, and low hemoglobin. Okay, so those are the reasons why a person could possibly, I would know those, have low oxygen capacity. Right here, oxygen intake and oxygen delivery, normal tissue oxygen needs and problems of oxygen intake with normal oxygen delivery. Right here, all this is just showing, um, I guess what you could say, a little scale and what happens when your body needs more oxygen or it doesn't. And so basically, that's where the lungs and the heart, and then the red blood cells. And so this is what happens as a result. You know how people have negative feedback. If your tissue needs more oxygen, this is going to increase, that's going to increase. Okay. Hazards and complications of oxygen therapy. Okay, you do need to know this. Oxygen does not burn but supports and enhances combustion. Oxygen does not burn but supports and enhances combustion. So that's the reason why they were saying, like, a lot of times you'll see people who have oxygen and they'll say, don't come light up, or don't come that. It's not the oxygen that's burning. It's just that whatever they have going on in their household at that time, like if they're smoking or whatever, it may enhance the flame, or it might make it worse where it could catch on to something and possibly burn the place down. The main respiratory drive is hypoxia. If there's hypoxia, drive is diminished by excessive oxygen treatment. Hypoventilation occurs and CO2 retention with possible cessation of ventilation. So basically, what they're saying by oxygen induced hypoventilation, it means that when a person has too much oxygen, which that's the reason why you don't want to turn up the oxygen level too high, then a person tends to not um they have what they call hypoventilation. There's no need to be trying to blow off nothing because their respiratory drive is less. So as a result, people tend to have an increased dioxide. Drying of mucous membranes, humidifier used if it's greater than 4 liters per minute. So that is one of the hazards also. You'll see with oxygen people, we tend to try to make sure we keep their mucous membranes high. Oxygen toxicity is oxygen level is greater than 50%. I want y'all to take this back and remember what the oxygen level is. We said it like the first slide, 21. Also, a person being on oxygen toxicity, which means poisoning amount of oxygen, their levels are greater than 50%, given continuously for more than 24 to 48 hours may damage the lungs. Depending on concentration of oxygen delivered, duration of oxygen treatment, and degree of lung disease. Absorption at a lactasis. Nitrogen in air help maintain patent airway and alveoli. When increased O2 levels is delivered, nitrogen is diluted. O2 diffuses from alveoli in circulation and alveoli collapses. So, infection, the oxygen equipment can harbor microorganisms, and you change your oxygen level based on, or clean it based on the regular protocol. And you can see that, especially if a person has some type of mask or something like that on, it can harbor abnormal organisms. Okay, so you have low flow oxygen delivery systems, and there is like a very what can I say? There's a distinct difference on whether something is low or high oxygen delivery systems. The lowest are the simple face mask and the nasal cannula. Here are the examples here. Um, Down at the bottom, you'll see where it's 1 liter to 6 liter, which is, and it delivers 24% to 44%. Um, and then you'll have the simple face mask, and it's minimum 5 liters, 40% to 60%. I would ask you guys to make sure that you guys memorize those numbers and know that, and just make a note of how these things are supposed to be delivered. Then you have what they call the partial rebreather mask, which is 6 liter to 11 liters, 60% to 75%. Then you have the non rebreather mask, which is 10 liters to 15 liters, or 90 percent. Low flow oxygen delivery systems. High flow oxygen delivery systems. High flow systems have a flow rate that meets the entire oxygen need and tidal volume regardless of patient's breathing pattern. It's usually used for critically ill people, and it delivers 24 to 100% at 8 to 15 liters per minute. It's face tint, aerosol mask, and what they consider a tracheostomy collar. You know, um, and I would a face tint used for facial trauma burns, aerosol after extubation or upper airway serve, or trach when a person needs that trach for whatever. Maybe they had a allergic reaction and had to get a trach because their respiratory passages closed down. I mean, there could be a number of reasons, cancer or something like that. So they have like what they call the high, which will be a Venturi mask, um, um, exhalation ports. Now, what I want you to know mostly about the Venturi um, mask is that it delivers the most accurate oxygen concentrations of all the masks. Flexible tube inhale mixture of 100% oxygen and room air combined is the most accurate, because it has like a little dial where you can actually put a real exact setting on it. A T piece. A T piece is a flexible tubing from oxygen source. Okay. Basically, like for instance, let's say this is an adapter. A lot of times people have this may be going to whatever oxygen, source, and it's like you'll see a lot of people that's on ICU, or if any of y'all go to a place like, for instance, if you go to somewhere like oh, I can't even think it, Kindred, or somewhere like that. You may see people, but a lot of these T pieces hook to people, cause like down here would be like if it hooks to a trach tube. This would be the section, and you connect it, and then the oxygen is here. Or if you see somebody, maybe you see people on life support or something like that. This is the T poop. Then you have non-invasive positive pressure ventilation, and that would mean a technique uses positive pressure to keep alveoli open and improve gas exchange without air intubation. BiPAPs and CPAPs. A lot of people who have sleep apnea uses these. Here's an example right here: continuous positive airway pressure CPAP. Patients who may benefit include those with atelectasis after surgery or cardiac induced pulmonary edema. It may be used for sleep apnea. Effect is to open collapsed alveoli. A lot of times you'll see people with CPAP, and they will be very, very restless and quiet, and very afraid and tired because they're getting no sleep because they can't breathe at night. So here is an example of a person right here on a CPAP. Okay, transtracheal oxygen delivery is used for long-term delivery of oxygen directly into the lungs. Avoids the irritation that nasal prongs cause and is more comfortable. Flow rate prescribed for rest and for activity. So on this section that I just went over, you guys, I want y'all to know all the little different delivery methods that I told you about, like the nasal cannula and the simple mask and the rebreather, and like I went over all of the different percentages and whatnot. And then like you want to know that the venturi is the most accurate, and these are just like things that you just really need to know, because they may come up on an exam or something, you know. Okay. Home oxygen therapy criteria for home oxygen therapy. Um, a lot of times, in order for a person to get home oxygen therapy, especially if they're on Medicare, they have to be maintaining on room air, which means without oxygen. A lot of times, y'all will hear them say, oh, a person's pulse ox was whatever it is on room air. That means that's without oxygen. Then when they put them on oxygen, their oxygen level is something else. So, of course, we've already talked about PaO2 levels and various things, um, and the SAT levels. But in order for a person to get it where they say, okay, this person needs oxygen in the home, it has to be less than 88% on room air. And you may not always see them spell out room air, they might just say RA. Okay, the patient education for use: compressed gas in a tank or cylinder. It's the most often used. It's economical, and pure oxygen is delivered. As you can see, this man right here, it's not real good for a person that's not homebound. Sometimes you'll often see people with the little, like a little, almost like a little backpack across their shoulder that holds the oxygen, but those are limited as much, time. They don't have as much time. Okay. Um, Sorry about that. Home oxygen therapy. I'm sorry, I had to click that back. Patient education for use. Um, I want you to know the differences. I want you to know the pros and cons. I want you to know, like for instance, when a person liquid oxygen in a reservoir. Um, this is an example right here. This lady right here of what I was telling you guys. about people who tend to get out more. It's really more expensive, and the oxygen gas that has been it's been liquefied. It's available in lightweight, easy to carry containers. So, con would be the fact that it may be expensive. The pro to a liquid oxygen reservoir that you can walk around is lightweight and it's easy to carry. Oxygen concentrator is least expensive. That's a pro, and it removes nitrogen, water vapor, and hydrocarbons from room air. And also, I mean, it's not really a good thing as far as being able to go out. That would be a con. The tracheotomy is the surgical incision into the trachea for the purpose of establishing an airway. The ostomy is the actual stoma. What you need to know is you need to know the difference. So when they do a tracheotomy, because sometimes you'll hear people using those words interchangeably, but they're not. The tracheotomy is the actual incision, and the tracheostomy is the actual stoma once they've performed the procedure of a tracheotomy. So the tracheotomy is like the actual procedure. And based on when they do it, it may be temporary or it may be permanent. Some indications for trachs include acute airway obstruction, need for airway protection, laryngeal trauma, airway involvement during head, neck, and surgery. A lot of times when they do these, it's like they need to do it right away. Okay, and that is like right here. So this right here, this part here, y'all see me pointing at, this is the tracheostomy, which is the actual stoma. And then when they say they're going to do a tracheotomy, that means that we're getting ready to make that incision. We're getting ready to cut. Okay. So for pre-op, you just got to focus on, the teaching aspect. Neck is extended, ET tube is placed, incision made exposing tracheal rings, second incision made through the tracheal rings to enter the trachea. After the trachea is entered, the ET tube may be removed while tracheostomy is inserted and secured with sutures. So they do it like that. And then depending on how long it stays it in, it may have to heal over, because if they cough out that inner cannula, then that's like a sentinel event. Post-operative care ensure patent airway, chest x-ray to verify proper placement, and confirm breath sounds. Possible complications assessment. Tube obstruction, which basically means that they can't get no air out. Um, and it may be due to thick, dry secretions, noisy respiration, difficulty inserting the catheter. Tube dislodgement occurs when the system is not secure. Accidental decantation, which means that you basically coughed out the inner cannula or something like that. Remember when you guys were doing your skills, we talked about how you hold that area in when you're doing the dressing change. It they say that it usually happens within 72 hours. And after that, I guess pretty much everybody gets pretty accustomed and it doesn't happen like that. You usually have to call respiratory to come back and put them in. Assess for pneumothorax can happen if chest cavity is entered during the tracheostomy, and that's usually at the apex of the lung. So make sure you look at your photo I had of the anatomy so you can know just right where that area is. The subcutaneous emphysema occurs when there is an opening or tear in the trachea and air escapes into the fresh tissue of the neck. Positive if skin is puffy and can feel crackling sensation. Small amount is expected as far as bleeding, but constant oozing is abnormal. An infection, assess the stomach for drainage, redness, pain, or tenderness to prevent use sterile technique when suctioning and doing trach care. So those are all of the reasons why we teach you to do what we do, especially when it comes to like bleeding and infection. You don't want so these are complications of a person having a trach. When we describe tracheostomy tubes, you're going to have disposable, reusable. You're going to have cuff tubes or tubes without a cuff for airway maintenance. Cuff used for patients receiving mechanical ventilation. Non-cuffed is used for airway maintenance when mechanical ventilation is not required. Intercannula, disposable or reusable, and a fenestrated tube when intercannula is in place, fenestration is closed, and it works like a double lumen. So basically, you guys, these are some examples of fenestrated tubes, and when that is and everything like that, those are some examples of the tubes. Just take a look at it. Moving on. Care issues for tracheostomy patient: prevention of tissue damage. Cuff pressure can cause mucosal ischemia, which means lack of air. Inflated um, cuff pressures again, or blood. I'm sorry, blood flow. Inflated cuff pressures against tracheal mucosa to reduce risk. Keep cuff pressure 14 to 20 millimeters of mercury. Use minimal leak technique and occlusive technique. Check cuff pressure often. Prevent tube friction and prevent and treat malnutrition, hemodynamic instability, or hypoxia. And make sure that you only suction when needed. Don't over suction. Remember how many times we said about as far as the passes. Okay, and here's a picture. Air warming and humidification. The tracheostomy tube bypasses the nose and mouth, which normally humidifies the warm and filter the air. So, um, tracheal damage can occur if you don't have enough humidification, because a lot of times what happens is it dries out and it cracks and whatnot. And then you have a whole lot of thick, dry secretions too that can occlude the airway. Air must be humidified, maintain proper treatment, temperature. Warming device can be used and ensure adequate hydration, which liquefies the secretion. And a lot of times you'll see respiratory therapy people when they come in and take care of trachs, and they got that little thing where they press on it. It goes down there to humidify the area. Suctioning. Suction maintains a patent airway and promotes gas exchange. Assess need for suctioning from the patient who cannot cough adequately. Suctioning is done through the nose, mouth, or trach. I want you guys to be real aware of when you pass. Like for instance, you won't pass and from the mouth and go into the trach or the nose or whatever. You got to know the order not to pass and send bacteria. Need for audible or noisy secretion. Crackles, increased pulse, wheeze, and increased respirations, restlessness, mucus, and artificial airway present. And these are all the different reasons why a person might potentially suction. If a person has an increased pulse, that's probably because they're worried and upset because of the fact that they probably can't breathe or pass like they normally would. Suctioning can cause tissue trauma, infection, vagal stimulation, bronchospasm, cardiac dysrhythmia from hypoxia. Like I said earlier in the previous slide, that a lot of times people have that because they have lack of oxygen and hypoxia itself. Causes of hypoxia is ineffective oxygen before, during, and after suctioning. So you can't be just sitting in there suctioning forever. That's why we tell you to suction as you pull in the catheter out. Use of a catheter that is too large for the artificial airway, prolonged suctioning time, excessive suction pressure, Intermittent, you guys, and too frequent suctioning. Prevent by hyperoxygenating the patient with 100% oxygen with an ambu bag attached to the oxygen. Before and after. Tracheostomy care. We've already discussed this. Prevent accidental cannulation is one of the main things that I will say to you. If you feel uncomfortable, it's always a good idea to have somebody come in there and hold that when you're taking care, because generally people, they do tend to cough, and you don't want them to suffer from decannulation. Keep tube free of secretions and keep ties clean. Okay. Turn and reposition every 1 to 2 hours. Support out of bed activities. Encourage early ambulation. The reason you do this is because you want to make sure that that patient is up, moving around, expanding their lungs, and that increases the gas exchange if it's at all possible. If not, if the person's bedridden, you just make sure that you turning them to help them remove the secretion. Cough and deep breathe. The use of chest percussion, postural drainage, and basically that promotes pulmonary function. Oral hygiene, avoid glycerin swabs or mouthwash that contains alcohol. Um, Once again, for the oral hygiene, you got to make sure that you avoid glycerin swabs or mouthwash that contains alcohol, because for one, it can dry them out. Assess mouth for ulcers, bacterial or fungal growth or infections. Keep airway patent, prevent bacterial overgrowth, dental caries, and promote comforts. A lot of times I see people that are not getting adequate oral hygiene when they have trace, and a lot of times you will see them with candida and all kind of little infections. So just you as a nurse, if you would make sure that you take care of people adequately, that would be good. Nutrition. Swallowing can be a major problem for the patient with a tracheostomy tube in place. If the balloon is inflated, it can interfere with the passage of food through the esophagus. Elevate the head of bed for at least 30 minutes after the patient eats to prevent aspiration during swallow. Um, Always remember, you guys, to elevate the head of the bed if they're eating by mouth, and that just goes. I mean, even if you think about when we tell you to do tube feedings and G tubes and everything, so this should be pretty easy to remember. Patient can speak with a cuffless tube, but a fenestrated tube or a cuff fenestrated tube that is capped or covered. So you have to cover like that area. Um, a patient can write. Make sure that if the person can write well, and phrase the question so that the patient can like have to just answer yes or no. And a one-way valve usually they have, it fits over the tube and it replaces the need for the finger. Occlusion can be used to assist with speech. And a lot of times you'll see people with trach have to cover that airway like that, and they'll speak for a second and tell you various things. Some people, they even have that cap to help them. Or you'll see people, they have that little voice box thing they use. Okay. And then here, once again, it's an example of a fenestrated tube and the cap and the trachea. Weaning from a trach tube. Weaning is a gradual decrease in the tube size and ultimate removal of the tube. A lot of times you'll see respiratory doing that. They'll be messing with their oxygen. They'll come over and it's just a little bit by little bit, just like you weaning somebody off of drugs or something. You just little by little get them less and less every day until they can tolerate. Because a lot of times their dependence on the ventilation is because it's more like psychological. Weaning from a tracheostomy. Change from a cuff to an uncuff, which makes sense. Size of tube is decreased By capping, use a smaller fenestrated tube. Tracheostomy button has a potential danger of getting dislodged. Be careful. Maybe removed if patient tolerates more than 24 hours of capping. Uh, Place dry dressing on stoma, which gradually heals on its own. Small score, a lot of times, will remain. And here are your review questions, and we'll go over those in class. I want you to try to look them up, and I'm not going to give you the answer, and read them on your own. And I'll print them out, and I'll bring the answers to class, and we'll go over them. Okay, the last chapter is chapter 31, care of the patients with non-infectious upper respiratory problems. The objectives of this chapter is to describe the basic nursing management of patients with upper airway disorders, review non-infectious disorders of the nose, sinuses, oral pharynx, tonsil, and larynx. Use the nursing process as a framework for care of the patients with upper airway disorder. Sometimes I just want to make sure that you don't feel that these are um, just words. So we're talking about people who have problems or disorders of their nose, sinuses, pharynx, tonsils, and larynx. We're talking it's upper, so that's your upper airway. And when we say non-infectious, we mean non-infectious. And as a nurse, we're going to talk about what type of things you're going to do to care for a patient that has these type of disorders. Okay, so once again, like we did earlier, here's anatomy of the upper respiratory system. You got the soft and hard palate and the areas like the tonsils and whatnot. Okay, so we're talking about disorders where a person is not infected of the upper airway. Okay, one of these disorders is a fracture of the nose. Um, Displacement of either the bone or the cartilage. Here's a good picture right here. You see the picture of the young man right here with the fracture of the nose, and then how they saying it look without the uh, as far as the skeletal anatomy. Um, or can be caused by it can cause an airway obstruction because of the swelling or cosmetic deformity, and it is a potential source of infection. Cerebrospinal fluid could indicate skull fracture. Interventions. Basically, where they go in and they do surgery, they do a closed reduction, a rhinoplasty, or a nasoseptoplasty. So, right here, you guys, is an example, real good example. Um, those are the only things. Um, Epistaxis, which is a nosebleed. Interventions if nosebleed does not respond to emergency care. Affected capillaries are cauterized with silver nitrate or electrocautery, and the nose is packed. And this is somebody who just has like severe nosebleeds all the time. Um, Posterior nasal bleeding is an emergency, and the reason why is because the patient could potentially choke. I am getting tired, so let's get going. I'm just like, okay, okay. Um, Assess for respiratory distress and for tolerance of packing or tubes. Administer humidification, oxygen, bed rest, antibiotics, and pain and medications. And that's just the nursing interventions that you would do after a person got their nose cauterized or whatever they did based on them having continuous nosebleeds. Nasal polyps. A nasal polyp, you guys, is benign, so basically that means that it's non-cancerous, and it's a grape-like clusters of mucous membranes and connective tissue. may obstruct nasal breathing, change character of nasal discharge, and change speech quality. Surgery basically is a polypectomy, which means that they just remove the polyps. And here is a picture here. Okay, and you see that right there. I know a lot of y'all may have seen this type of thing before. Uh, and cancer of the nose and sinuses, tumors of the nose and sinuses is rare and can be benign or malignant. Onset is slow, and manifestations resemble sinusitis. So you'll have swelling, be a little sore from here and there. It's just off and on. Local lymph enlargement often occurs on the side of your neck or whatever with a tumor or mass. Um, they usually try to reduce the tumor, and then after, and depending on what it is and where it is, they may do surgery as well. It just kind of depends on the individual. It's an individual basis. Also, the next thing is the facial trauma. That's and that could happen for any um, reason, and basically they have different. Right here, I just wanted to show you those, and these are the type of uh, traumas. See how it look in the front that they describe, and it's Lafort 1, 2, and 3. And so let's go back to the one before. And um, one, of course, not as bad. Two, a little bit more complex. And the three, combination of one and two plus an orbital zygoma fracture. And only thing I would want y'all to know, basically on the facial trauma, is to make sure that you always assess airway first. Okay, cancer, the nose and sinuses. Um, I want you to know that the nose and sinuses is rare and can be benign or malignant. Onset is slow and manifestations resemble sinusitis. Um, Let me see. I think I did that all right. Okay. Okay. So when I told you about the facial trauma, I want you to assess the airway, anticipate need for emergency intubation, um, and then, like I told you before, these are some of the remedies, and we've already talked about things like tracheotomy and everything like that. Because if there's always a potential where the swelling, as a result of the swelling from the facial trauma, there may be a need to intubate or do a tracheotomy. It depends on what the location is. Obstructive sleep apnea. I want you to know that definition: breathing disruption during sleep that lasts at least 10 seconds and occurs a minimum of 5 times in an hour. So I want you to know that that's the characteristic where they stop breathing for at least 10 seconds at a time, and it happens on average at least 5 times in the hour. So that's pretty much. And remember earlier, because I think I got a little ahead of myself, we were talking about excessive daytime sleepiness and inability to concentrate, and the reason being because of the fact that they're up all night. Their sleep is getting interrupted, and so they'll be irritable, and they won't be able to concentrate because they're tired. So basically, when they have obstructive sleep apnea, it's usually you can do either non-surgical management or surgical management, and it kind of depends on what the underlying reason is for the sleep apnea. Remember earlier we talked about positive airway pressure and people having the CPAP and the BiPAPs. Okay, disorders of the larynx. You can have where you have vocal cord paralysis, vocal cord nodules and polyps, and laryngeal trauma. Um, so a lot of these could be potential reasons why, like a person could have nodules and polyps, where they could be obstructing their breathing, paralysis, or they could have had trauma as well. And here is an example right here. When you have an upper airway obstruction, know for sure that it's life threatening emergency in which an interruption in airflow through the nose, mouth, pharynx, or larynx may occur. Early recognition is essential to prevent further complications, and remember, including respiratory. This can include as well respiratory arrest. Interventions include assessment for cause of the obstruction, maintenance of patent airway, and ventilation. Um, the surgically they could do a cricoid thyroidotomy, and of course we already talked about endotracheal intubation and a tracheostomy. A person who has neck trauma, it may be caused by a knife, gunshot, or traumatic accident. The priority nursing care with a patient with neck trauma, once again, like we always say, you guys, is airway. And of course you're gonna assess first. When you get the first thing is gonna be the airway, then you can assess other parts of the system, and also make sure that you prevent them moving their neck. And then we talked about head and neck cancer. You want to get the history related to that. Do a psychosocial assessment, laboratory assessments, imaging, and other diagnostic. And here's a picture. We talked about this a little bit earlier. And here are the different types of therapy: radiation to reduce, possible chemo. You might have to remove their voice box. You know, it could be a lot of different interventions. Usually, it's not like no one, you guys. What I would want you to know is what would a person do as a result of this as a nurse? What would you do palliatively? Like if a person was getting radiation therapy, chemotherapy. What is the therapy, the nursing interventions after a chordectomy? What you need to do is just read over the nursing interventions. And throat after laryngectomy. Okay. Okay, so like for instance, if you have the first priorities after head and neck surgery is what? Air maintenance and ventilation. Um, if they have like a wound or a flap or whatever, you're going to take care of that to prevent infection. You're going to make sure they're not bleeding. You're going to do pain management, nutrition, which is really, really big, and speech and language rehabilitation. If you were to look at the order that these are prioritized, if I was you, I would just really take notice of the way that it's prioritized. Remember we always talked about maintaining the ventilation. Remember how I always told you about taking care of the physical. So you're going to take care of the wound, flap, and reconstructive tissue. You're going to make sure they're not hemorrhaging, which is safety. Um, then you start getting into all the little comfort levels: wound breakdown, pain management, nutrition, and speech. So, I mean, when you talk about all of these, I'm not minimizing, but all of these are important. But if you come up on a question where they say, we want you to prioritize, you need to take notice of that. Okay. And then right here we talk about speech after laryngectomy. We already talked about that. Okay. And then, of course, community based care, and stoma care, communication, and smoking cessation, and how people feel about the aspect of having some type of trach or something going on based on them having cancer. And then before we close, we got a last little uh, video. Did you see this, Denise? Excuse me, guys. Did I show it? That's an ad.
A lung is a guy who thinks he's flying, is located in the thorax, always helping us with our breaths, bringing O2 stat to the max. So, no, I don't want your cigarette, no, I don't want to breathe in smog, and no, I don't want pulmonary embolism, I want to go for a jog, no, I don't want no rails, a rail is a crackle from fluid in the lungs, it can be fine or coarse in an airway source, discontinuous, I don't want no wheeze, a wheeze is high-pitched and heard when you breathe out, caused by an obstruction from secretions, so you could have asthma.
Nurse is checking me and my lungs are feeling weak.
And I'm sitting in the tripod position, and the nurse is telling me I have COPD, so an open airway is my mission. No, I don't want productive cough, I don't want shortness of breath, no, I don't want pain when breathing, no, I don't want none of that mess, no, I don't want no rails, a rail is a crackle from fluid in the lungs, it can be fine or coarse at an airway source, discontinuous, I don't want no wheeze, a wheeze is high-pitched and heard when you breathe out, caused by an obstruction from secretions, so you could have
If you're
asthma.
inspecting and you see blue lips, oh yes, lungs, you ain't got enough air.
If you're palpating and you feel popping, oh yes, lungs, you have crepitus.
If you're percussing and you hear donuts, oh yes, lungs, you full of fluid. When you auscultate and you hear a gray, oh yes, that is pleuritis. Bad
Lungs, stride, dirt, no resin, ends, free of lesions. I don't want no rails, a rail is a crackle from fluid in the lungs. It can be fine or coarse in an airway source, discontinuous. I don't want no wheeze, a wheeze is high-pitched and heard when you breathe out, caused by an obstruction from secretions, so you could have asthma. I don't want no rails, a rail is a crackle from fluid in the lungs. It can be fine or coarse in an airway source, discontinuous. I don't want no wheeze, a wheeze is high-pitched and heard when you breathe out, caused by an obstruction from secretions, so you could have asthma.
Okay, everybody. All right, we'll see you in lecture tomorrow. Thanks. Bye.